Hi, everybody. I want to thank everybody for joining us today. My name is Robert Kinne. I'm an interventional spine and sports medicine doctor who practices in Decatur, Indiana, not too far out from Fort Wayne in Northeast Indiana. And it's a pleasure today to join everybody to talk a little bit about low back pain and specifically spinal stenosis and discuss symptoms for patients, but also a new treatment option that we've been able to provide here in Northeast Indiana. And we're excited to say that we're the first practice and system in Northeast Indiana to provide this exciting new treatment option. With that, if anyone has any questions afterwards, you all have a phone number there. And I want to thank Boston Scientific for hosting this. And they can always get my contact information for anybody that wants to find out more. So with that said, next slide, please. So first and foremost, what is a pain management specialist or interventional spine medicine specialist? First of all, my background, I'm originally physical medicine and rehabilitation trained, and then did a couple fellowships after that in both sports and then interventional spine medicine. So we're trained in the evaluation, diagnosis, and treatment of kind of all over body pain, but especially what I like to call musculoskeletal pain. So muscle, bone, and inevitably a lot of it's connected to the spine. Our treatment approach is to really identify the cause of symptoms and pain in a patient, and we really take a holistic approach to that. Our goal is to reduce the severity of the pain and try to improve quality of life and specifically function for those patients. Specifically, one thing that led me to Adams Memorial was their dedication to providing newer minimally invasive treatments for pain generators and disease processes that used to only really have a large surgery as a treatment option. And so, with that said, we really focus on trying to get similar or even sometimes with newer options, like we're going to talk about today, the same outcomes with more minimally invasive and lesser risk procedures. And so that's kind of our approach. Next slide, please. So then why we're here today to really talk about something low back pain and specifically something called lumbar spinal stenosis. We want to talk about the fact that this is pretty prevalent in the community, and a lot of patients are dealing with this. So what do these patients feel? First of all, you can see on the left-hand side of the screen some very common things that we hear in our clinic from patients that come in with back pain that they've been struggling with for quite some time. Some people will say, I have low back pain that gets a lot better when I sit, but boy, anytime I try to stand or specifically walk, I'm really limited. So you can see some options on the left-hand side of the screen here, where people will have tried pain medications by the time they get to us, and they're just not working well enough. They might make them feel better for a short period of time, but boy, they're still limited functionally. Specifically with spinal stenosis, we see a lot of patients who can get around in short spurts, but aren't able to do it for any kind of prolonged distances. Not included here on the left-hand side of the screen is a common complaint I hear is our patients talk about, I can't even walk to the mailbox anymore. I used to be able to walk 2, 3, 4 miles a day. I was very active, but no longer. I get a block, 2 blocks, and I've got to sit down. And so really, these are some common complaints that patients have. We try to identify because we're able to provide some newer options rather than just physical therapy, which was our initial approach, and then skipping over and going straight to the surgeon. Next slide, please. Kind of talking about what are those initial approaches. First and foremost, we want to identify the entire cause of the pain. Oftentimes, back pain in and of itself as a complaint can be from a very large possible range of causes for the patient. And so we really have to kind of get down to what specifically is causing this patient's back pain. For that reason, we ask questions about function. We test them on initial exam. We don't just look at an MRI, but we also want to try to identify, hey, are we weak in some portions of our body that are exacerbating our symptoms? Is there anything musculoskeletally imbalances, like I said, muscle weakness, that could be addressed first and foremost before we try to identify something larger as far as a treatment option for them. And so oftentimes when patients have been dealing with back pain for quite some time, they do have some deficits when they come in, some muscle imbalances, some muscle weakness. And so first and foremost, we have a conversation about physical therapy. Maybe by the time they get to us, they've been in their primary care provider's office, they've been complaining of this for some time, they had an initial workup, and maybe they were started on some medication. Oftentimes by the time they get to us, they've had a short course of opiate pain medications, which we really use in our practice as a quote unquote last ditch option. But they may have tried some of that, and that's been the only thing to work for them. But they feel like it's not lasting a long time, and it only minimally improves their function on a daily basis. Other types of treatments after we failed some initial options such as therapy, some strengthening, flexibility, range of motion exercises, anti-inflammatory medications, or even nerve pain medicines. We might look at the possibility of trying an epidural steroid injection to better control their back pain, depending on the cause of it. And then traditionally, the next steps after that, if they're not getting better, would be looking at options such as radiofrequency ablation, still a minimally invasive procedure, but kind of taking that next step. And then after that, if they did suffer from continued limiting symptoms, we would have a discussion about whether they may need to talk about higher level options from a surgeon, and whether that's a laminectomy or even a spinal fusion. Additionally, some of these patients may have had a discussion or even had a spinal cord stimulator placed in the past. And so next slide, please. Going back to what we were talking about earlier, this is a very common problem, a spinal stenosis is. As you can see, it affects more than 14 million Americans. It's the term that I like to use is it's truly a disease of maturity, more times than not. And oftentimes we see this in older patients. And as you can see there in the fourth bullet point, it is the #1 reason for spine surgery in patients over the age of 65. It is, as degenerative diseases go, if left untreated, it can continue to worsen with time, and truly restricts a patient's mobility and quality of life. Next slide, please. So what is it? Generally speaking, I like to say that stenosis is just a fancy term for narrowing. And we've got a couple different regions within the spinal canal that the narrowing can occur, but oftentimes we have narrowing within that spinal canal made by the bony vertebrae, which inevitably ends up compressing the nerves and neural components. And the symptoms that the patients experience is that they get worsening back pain and or leg pain with standing and especially walking. When they're able to put their spine in forward flexion, which one is able to do not only by leaning forward, but also by sitting down, that pain is relieved. And so there are numerous causes of that general narrowing, but oftentimes with maturity, when we have things like arthritis, when we have things such as our ligaments become stiffer and may enlarge over time as they stiffen, that narrowing can become more and more prominent. I think I like the diagram here on the left in the bottom hand left portion of the slide that really shows that central spinal canal with the nerve roots running up and down right in the middle there with looks like yellow dots. And you can see in a healthy person how that space is relatively wide open. But you can see kind of outlined in red there right in the middle on the stenosis picture where we can get compression with standing again and lumbar, what we call lumbar extension. Next slide, please. So what is the Vertiflex procedure? You know, first of all, some general comments on it. It is FDA approved. It is truly minimally invasive. And what do we mean by that? This is a procedure done through essentially a large needle, and you can see the titanium implant on the right side after placement. And it's even smaller when it's placed through the large trocar that we use, or the large needle that's hollow, and we slide it through there and place it in between the spinous processes of the vertebrae. What does that entail? Approximately a 15 to 20 minute procedure with a very small incision, oftentimes requiring just one, maybe two sutures. It's a same day procedure. It does not require any removal of bone, and I think that's one of the biggest features and things that make me and us excited to do this at Adams is that you get to keep the vast majority of your native parts in doing this procedure. Unlike any of the other more traditional surgical procedures, once you lose those parts, whether it's a piece of bone, whether you end up with screws or rods or hardware in there, those are not reversible. This truly is a procedure where it doesn't eliminate you from considering further or more invasive surgeries in the future if, heaven forbid, they're necessary. And so it really is a very logical step, in my opinion, to consider before you were to go and get a larger surgery for this. Because it is minimally invasive, because it doesn't require a lot of cutting or removal of tissue or bone, there's a quick recovery time in comparison to most spine surgeries. Oftentimes, we limit patients' significant physical activities for a couple weeks, and if they're doing well, I see them back at just a few weeks afterwards, and we start to progress them quickly through therapy. Oftentimes, at that 6-week mark, they're back to even higher level physical and sports activities if that's their goal to get back to. Again, kind of focusing and harping on this minimally invasive idea and approach, there's a low risk of infection and complications. At our facility in Decatur, we also don't require full sedation for this procedure. It's really well tolerated. We use conscious sedation, the same if you've ever had something like a colonoscopy or an endoscopy. And so that lowers the risk of anesthesia for the patient as well. And then finally, as you can see in the lower left, more than 10,000 patients have been treated since 2016. Next slide, please. So how do we do it? We kind of talked about that on the last slide. There's a nice video here on the right. You can see the trocar being placed, the titanium implant inserted through the hollow tube. It expanded. We use a spacer to measure each patient individually on what size best fits them. And then we slowly expand during the procedure. And so as you can imagine, there's not a whole lot of time or removal of any parts either. And then the only real, the main reason for precautions following the surgery is we would like that titanium implant to scar into place. And so we don't want the patient moving around, doing any kind of repetitive heavy lifting or significant athletic or physical activities, because we want the time for the body to kind of heal that into place around there so that it doesn't move afterwards long term for the patient. Next slide, please. So what to expect after the procedure? We went into a little bit the recovery time. Oftentimes, like I said, it's just 1 to 2 sutures following the procedure. The stitches are on the inside, and we remain covered for a couple days to minimize the risk of infection, but you can still shower. Like I said, we limit higher level physical or strenuous activity for about a month and a half afterwards, to allow that implant to heal, or your body to heal around the implant, I should say. But we oftentimes at just a couple weeks start you into lighter physical activity. We want you to get moving, and increase blood flow to that area, so that we get healing post-operatively for you. You can be a little bit sore, but when we compare this to the more traditional surgeries that we've talked about, we're decreasing a lot of the post-operative pain, as well as the recovery time, as we've discussed. Next slide, please. So the results are real. I think one of the biggest, most exciting parts of this procedure for me is some of the data that came out about Vertiflex. That really is what sold me on wanting to bring this to Northeast Indiana, providing this for patients. And I think the biggest part to this is that oftentimes in the world of spine pain and low back pain, when we look at surgical outcomes or even treatment outcomes in general, even from epidural steroid injections, which has been classically used for decades for patients to try to provide pain relief for them, we see the results or the relief that are provided, one, aren't very good, and two, they just don't last very long. And so when Vertiflex came along, the FDA had them look at 5-year outcome data, and you can see some of the statistics on the left, which you just don't see in spine pain and spine surgical outcomes. So you can see that, again, at 5 years, which is a long time, 9 out of 10 patients are satisfied with the procedure. There was an 85% decrease in patients using opiates. There's over 80%, greater than 4 out of 5 patients had improvement in physical function, and greater, 3 out of 4 patients had a significant reduction in leg pain symptoms. You can see a couple examples of patient responses there on the right as well. Next slide, please. So what else do we consider? When we talk about spinal stenosis, the key thing that we have a discussion with patients about, and we should have talked about this in the beginning, but a key factor, if I didn't touch on it enough, is that the patients have to have relief with lumbar flexion. Again, that's sitting down. That's those patients on that previous slide that talked about when I walk down the supermarket aisles, I have to lean over on the shopping cart, or I have to walk with a cane hunched over because that gives me relief. If patients have low back pain that persists and is limiting, but they don't find significant relief when leaning forward, that typically is not lumbar stenosis or spinal stenosis mediated pain, and they're not a candidate for the Vertiflex procedure. But that does not mean that there might not be some other treatment options that we offer, and one of which is a spinal cord stimulator. Just briefly talking about that, that's where we take 2 electrical leads. Simply put, a spinal cord stimulator is kind of like a pacemaker for the spine, and so you take two wires essentially with some electrodes on the end of them. We place them behind the spinal cord, and they emit a constant electricity that's either felt or not felt, depending on the patient preference, but essentially blocks the pain signal from getting from the area where their pain comes from, the low back, up to the brain. So it's not fixing their low back problem. It's not stopping that disease process from happening or have already happened, but it's stopping the pain signal from getting to the brain. And it is a pretty good option in the right patient population. Next slide, please. Additionally, something we do a lot of where we're at is radio frequency ablation. And and again, this is a procedure that can mimic spinal stenosis, in that patients oftentimes have a problem standing up. And so, but this is more of a problem directly due to the arthritis in some of the smaller joints on the backside of the spine. And we oftentimes will discuss these options with patients even before the Vertiflex procedure, depending on the symptoms. This is a even more minimally invasive procedure or treatment option than Vertiflex. And so there are a subset of patients where we will try this as a treatment approach prior to Vertiflex if they're appropriate candidates. But again, it's minimally invasive. It's done through really specialized needles, and really well tolerated. The whole thing takes about 15 minutes. Patients don't experience much except a little bit of stinging from the numbing medicine. And the way in which we do it at our facility, and I'm a big advocate for, is that there is no sedation required except for some local anesthetic. Patients do really well with this, and they tolerate it really well. If they're very nervous about the procedure, we may give them a Valium, a pill to take to help them with anxiety prior to the procedure, but overall patients do very well. Next slide, please. So frequently asked questions, and you all can read through these in detail, but I think most of the questions that I get, or the parts that I see most in my practice, are questions from patients that say, how long should I expect the relief to last? And that's where we talk about that prior slide, where we can look at that 5-year data, and we have really good outcomes. Other questions I get are, oftentimes I'll see a patient after they've been to a spine surgeon, had a consultation, maybe a couple spine surgeons, and they're told that they're not a candidate for surgery for whatever reason. Oftentimes it's due to medical comorbidities. Because we don't require general sedation, because this is a very short time frame, minimally invasive procedure, a lot of these patients will be candidates for the Vertiflex implant. And I think there are a lot of people out there that think that they don't have many options besides medications and maybe some epidurals, and they're living not only with pain but also functionally impaired, and they end up becoming really good candidates for the Vertiflex procedure. And so that's, again, one of the neatest things about this procedure is some patients that don't, even if they could be helped with a larger spine procedure, they can't even get that because of some other medical issues. But Vertiflex can step in and really help these people that otherwise wouldn't be able to get the relief they're looking for. Is it covered by Medicare and Medicaid? Yes, it is. We talked at length kind of about the recovery time, but all in all, typically we're looking at 6 weeks, and then you're back to full activities, which again is significantly improved from some of the larger, more invasive spine surgery options. Does it relieve your pain immediately? That's another question that we're frequently asked. And some patients, yes. We just had one a couple of weeks ago that had multiple people. She came in so happy because the second day after the procedure, she went to church and had multiple people around her tell her, "You're standing up straight. We can't remember the last time you stood up straight." And that just thrilled her. And so that was really neat to hear. But while some people do get immediate pain relief, not everybody does. It can take a matter of weeks. And so I like to, kind of discuss the expectations that while we hope for immediate pain relief, that's not always seen. But certainly within a matter of weeks, we should be seeing that improvement. Next slide, please. So I think actually, if can we go back one more slide? I think there's one more point that I wanted to make or re-emphasize, just in the very first question there. If they've had prior treatment, are they still a candidate for Vertiflex procedure? Candidacy for this intervention and treatment option is key. And And so one thing that we look at, if there's any kind of spine mobility, especially for the referring providers that might be watching this, we look for instability in the spine. That's one thing that Vertiflex might not be the ideal treatment for. That doesn't mean though that they might not qualify for some of these other treatment options. But I think the biggest thing I wanted to talk about or re-emphasize is the fact that Vertiflex does not prevent you afterwards. If 5 years, 10 years, 15 years down the road, your disease progresses for some reason, unfortunately, you can still go get the more invasive, higher level surgeries that might be options for you. But the other options, non-surgical options, whether that's radiofrequency ablation, whether that's epidural steroid injections, those don't rule you out for the Vertiflex procedure either. And so, in our practice, we really, if the patient is a good candidate as far as their anatomy goes and their spine goes, it is a very logical step from some of the more minimally invasive procedures such as physical therapy and medication. Instead of traditionally jumping straight from that to a surgery, we might try an epidural or a radiofrequency ablation first. But if they're not getting long-lasting relief from that, Vertiflex is a very natural option and consideration that we talk about with our patients prior to going to have bone cut out of their spine or rods and screws placed as well. Next slide, please. So I think this slide is really just talking about that functional component that we always emphasize, and I hope everybody that's seeing their providers and physicians for that has back pain is really focused on. While we would like everyone to live pain-free, I think I tell our patients that our #1 goal is to get you back to doing the activities that not only you need to do, but that you like to do. And quality of life is really what we focus on. And I think where Vertiflex really has the potential to provide assistance in achieving the goals of getting back to improvement, and daily fun activities that our patients want to be doing. Next slide, please. So again, I just want to thank everybody for joining us, taking the time. I tried to keep it quick. I know everybody's probably has busy schedules, but I'm passionate about this. I'm passionate about helping people get back to life, really. And I'm excited to get to offer some of these minimally invasive procedures that I think really has a better potential to get people back to doing the things they love to do. And I think Vertiflex fits really well into our practice and is a really good option for a lot of patients out there that at least in Northeast Indiana, haven't been able to even consider it as an option up until now. And so if anyone has any questions at all, please don't hesitate to contact us. I'm happy to help in any way we can. And thanks so much for joining us today. Have a good day.